Good morning, everybody. Thanks to Meryl and the organizers for inviting me. This is a great meeting, and I'll try not to talk all day about a topic that's very near and dear to my heart, and that's looking at pregnancy and cardiac disease, and specifically today, pregnancy and heritable thoracic aortic disorders. I have no conflicts of interest. So the objectives that I've been tasked with today include the following. So discussing the surgical thresholds in those contemplating pregnancy, imaging in pregnancy, medical management in pregnancy, and then IVF and pre-implantation genetic diagnosis. So some of the initial objectives have sort of been alluded to, and we'll talk about them in a bit more detail now. I'm going to start off with presenting this data. So this is data from the UK Confidential Inquiry. So you may or may not be aware that the UK goes back and looks at maternal mortality in 3-year spans. So the most recent data was published in 2018, reflecting maternal mortality causes between 2014 and 2016. And so they look at direct causes and indirect causes of maternal mortality. And publication after publication, so they've been doing this for years, cardiac disease is the leading cause of maternal mortality and the leading cause of indirect maternal mortality. And 20% of that is related to aortic dissection. So this is a really important topic to be discussing. And what's interesting is they took it a step further in this particular publication and went on to look to see would improvement in care have altered the outcomes, because that's really the point of this particular publication, is what can we do different? How can we improve maternal mortality? And so they looked at the various subgroups of cardiac disease, ischemic heart disease, valvular heart disease, and so on. And you can see under aortic dissection that they sort of estimated, or when they went through all the cases, they felt that in 15% of those maternal mortality cases that were related to aortic dissection could have been prevented by an improvement in care. So there's a really good reason, again, to be talking about this. What's happening in the United States? Well, we know that maternal mortality has actually increased in the US for the past 3 decades. So that's a bit different than what we're seeing in Canada, where it's actually declining. But in Canada, there's no sort of formal data on this, but in Canada, the cardiac disease as an etiology for mortality sort of remain relatively stable. But in the US, 33% of maternal deaths are attributed to cardiovascular disease, and it's felt that 25% of those are thought to be preventable. So we have a lot of room for improvement as practitioners, and I think that some of our patient experiences further highlight that. So I run the Cardiac Obstetrics Program in Vancouver. We see a lot of patients from all over the province, but by no means are we capturing everybody. And so a few discussions that I've had with patients, this is just over the last 6 months, and they're actually both from patients that have inheritable aortopathy. One landed in my lap, Marfan syndrome, with an aorta of 45 and a malignant family history of aortic dissection, and was sent to me at this time when she said, I'm on my 3rd embryo transfer, and I'm now learning that it may not be safe for me to become pregnant. So was I ever the bad guy when I sort of had this conversation with her that maybe it wasn't the best idea, when in fact she'd been seeing a very good cardiologist out in the community who hadn't really gone through this in detail with her. And then another patient, and this is where the guilt comes in for some patients, is I didn't know that birth control was safe for me to take. I was unsuccessful and became pregnant. So there's a lot going on there. So what is it about pregnancy? Well, there's the hemodynamic changes. I'm sure many of you have seen this slide before. There's up to a 50% increase in cardiac output. That's related to an increase in plasma volume, a reduction in systemic vascular resistance, and an increase in heart rate. And so these changes occur over the course of pregnancy, but really peak sort of in the 3rd trimester. And I don't show it to you here, but postpartum, there's even a further increase in hemodynamic changes when you have uterine contraction and this excess of blood that's pumped into the circulation. So postpartum is also quite a bit of stress from a hemodynamic perspective. And then there's the pregnancy hormonal stressors. And so you know that over the course of pregnancy that estrogen and progesterone continue to increase until the time of delivery. And then hormones have varying impacts on the big arteries and small arteries. But if you look at estrogen, it increases the release of MMPs, causes cystic medial necrosis. So you're creating this vulnerable vasculature in pregnancy in all women. So it's not just women with heritable aortopathy or bicuspid aortic valve. But then when you have that overlying diagnosis, you have further changes that take place. Reticular fiber fragmentation, elastic fiber disorganization, the hemodynamics on top of it. You may or may not develop hypertension, preeclampsia, if you had fertility treatment, which we'll talk about in a bit, and if you're carrying more than one fetus, all putting you at risk of aortopathy, further aortic changes, and possible dissection. So what is the risk of aortic dissection in pregnancy? There have been a lot of reports that have looked at this, and it's anywhere from 1% upwards of 10%, and really all of these publications are retrospective in nature. Some have aortic measurements, others don't. But in general, what we say is that if the aorta is less than 40 millimeters, the risk of an aortic dissection is thought to be low at 1%. But if you're above that level, then it ranges anywhere from 4 to 10%. But we'll talk a little bit about that. The most recent publication is not entirely in agreement with that. It was published in JACC 2014 by Angie Yetman, and they looked at 199 pregnancies. So it was a fairly large study as far as this kind of work goes. And there was a median of 3 pregnancies for each woman. So women had repeat pregnancies. But what's interesting in this particular study, as you can imagine, it was retrospective as well, that the initial aorta measured 36 plus or minus 4 millimeters. So they're not really capturing a lot of women with larger aortas. 27% had aortas that were greater than or equal to 40, but again, the vast majority were less than 45. And in this particular study, there were no aortic dissections or intervention from a cardiac surgical perspective. There were 2 carotid aneurysm dissections and 1 heart failure due to severe AI. So what this group then indicated is, well, you know what, the risk of dissection is low. Again, less than 1% in women who have an aorta less than 40, and that's where this comes from. What they also found, which is very interesting, was that they looked at the growth of the aorta during pregnancy. So if you look at that top figure there, you see that in fact the rate of growth in pregnancy is much higher than it is, pre-pregnancy or post. And what that means is that these women are having some changes, as we've talked about already, over the course of pregnancy, and they found that that puts these women at increased risk in the future. So although this particular publication didn't necessarily show an impressive rate of aortic dissection, albeit the aortas were smaller, certainly having been pregnant is a risk factor for having elective surgery in the future or an adverse outcome in terms of aortic dissection. So what's the things to consider? The main thing is preconception. I think that everyone in this room is probably well aware of this, but I think it's educating the community, bridging that sort of knowledge gap, is these women need to come to attention pre-conception. So they really can have a good discussion around what the maternal risk is, what the fetal risk is, the importance of multidisciplinary team care, follow-up through pregnancy. All of these discussions need to take place. Medical management and follow-up. So many of ththese women may be on an ARB and ACE inhibitor. The fact that they need to come off of that is another part of the discussion. And then, of course, ensuring that you have complete imaging of the aorta. And I say MRI imaging of the entire aorta because that's what you can use as a comparison while they're pregnant. MRI imaging of the spine, genetic counseling. And then if pregnancy is not, something that they're considering in the short term or maybe is high risk, ensuring that they're on adequate contraception so they're not left with this myth that there's no option for contraception, because there absolutely is. On the bottom there, I show you some guideline data. And so this is from the European Society of Cardiology Pregnancy and Heart Disease Guidelines that were published in 2018. There was another one that was published in the early 2000s, but there's a recent document. And so throughout it, I'll sort of highlight things. But what you're going to notice is that the level of evidence is C throughout, right? So there's not a lot of evidence for what we do, especially in the pregnancy literature with respect to heritable aortopathy, but there's a lot of expert opinion, as you can see by the classification of 1. So if we move on, I'm just going to bring up a case here, and we'll talk about it a little bit later again, but this is a 33-year-old woman, her first pregnancy at 17 weeks of gestation. So that's when she was referred, or we learned about her, was at 17 weeks of gestation when she came to our clinic. She had already had a diagnosis of Marfan syndrome on the basis of a family history, and her meeting the Ghent criteria. No family history of dissection, and she was sent to us on Nadolol 40 milligrams daily. She had not had any imaging of her aorta in the preceding 5 years. And so we had no imaging of the aorta leading up to this pregnancy. And so we did an MRI in pregnancy. We'll talk a little bit about that. Sinuses of Valsalva measured 38. That was her maximal dimension. Nadolol was increased to 80 because she would tolerate it. And throughout her pregnancy, she was stable. I'm really summarizing this for you. Her systolic blood pressure remained low. And then she had echocardiograms, and her ascending aorta was stable by echo. And so I'm just going to ask for a show of hands. Who thinks that her risk of dissection is low? Moderate? High? Okay. So risk assessment, this is subjective, right? So in your mind, you're balancing, well, you know, we know that they have these hemodynamic changes, these hormonal changes. What are the risks? Well, we know aortic size is a risk, aortic growth during pregnancy. That's why you're monitoring these women. You know, if they're going to present with a dissection, they usually do so clinically. You know they're having a dissection, but if their aorta is growing, you have to monitor them throughout the course of the pregnancy, the type of aortopathy that they have, whether they have a history of dissection. So I put that on there because you'd be surprised. Some women who've had a history of dissection will still turn up pregnant, or there's varying opinions on that. If someone's had a type B dissection, some people may think that it's safe for them to have a pregnancy. History of aortic surgery. Having had aortic surgery on the ascending aorta does not prevent them from having a type B dissection. A family history of dissection. What's their genetic mutation? Do they develop hypertension or preeclampsia during pregnancy? What are the other associated lesions? Maternal age, and then other unknown factors. So this is a table from these ESC guidelines, and I've highlighted in red what is really important for today's discussion. So if you look here, you know, you've got WHO 1, 2, 2, 3, 3, and 4. And you can see that the maternal cardiac event rate is prohibitive in WHO class 4, right? So this is for all cardiac disease. And the rate is quoted at 40 to 100% of having an event rate. And in WHO 4 class, pregnancy is absolutely contraindicated. And so when we're talking about aortopathy, you're essentially looking at severe aortic dilatation. So greater than 45 millimeters in Marfan syndrome or other heritable thoracic aortic conditions, greater than 50 in bicuspid aortic valve, and in Turner syndrome greater than 25, right? So the threshold for intervention is at 26. And then if they have vascular Ehlers-Danlos, doesn't matter what their aorta is, they're extremely high risk and pregnancy is contraindicated. And then when you look at WHO class 3, these are people that are still at quite high risk of maternal mortality and morbidity, but pregnancy is not contraindicated, but this is where the discussion comes into place. And so when you look at WHO class 3, moderate aortic dilatation, so in the range of 40 to 45 for Marfan syndrome and heritable thoracic aortic conditions. And so that's that sort of intermediate range where we don't really know what to do with these patients. And some people would actually advocate, and I'm of that mindset as well, that if you're in Marfan's of 40 or heritable thoracic aortic or Loeys-Dietz, that maybe you shouldn't get pregnant, and that's a discussion you have with your patients. Turner syndrome, 20 to 25, and then tetralogy of Fallot with a dilated aorta. And the WHO class 2 and 3 is Marfan or other heritable thoracic aortic without aortic dilatation. And WHO class 2 to 3 is still not low risk, right? These are still moderate risk patients. So patients with heritable thoracic aortic disease with no aortic dilatation, the thought is you're still at some risk. So if we go back to this particular lady, she then, at 38 weeks, had an elective, uncomplicated cesarean section. This was in discussion with her obstetrician. There was no cardiac reason for the C-section. And then 8 days postpartum, developed sudden onset of sharp back pain. Her blood pressure was 176/78, and she had a type B aortic dissection that extended down to the renal arteries. She was transferred to the ICU for aggressive BP control, discharged after 14 days, remained stable. But I think I choose this case to really highlight the fact that no woman with heritable aortopathy is really at low risk during pregnancy. You know, they may not be high risk, but I always give that message that you're not low risk. I can't necessarily quantify it. There's no data to help us quantify it, but you're not low risk. You always run the risk of running into issues. So surgical thresholds, managing risk. I'm going to present to you this summary slide. There's the ESC guidelines. They don't actually directly address when you should be intervening preconception on the aorta. And some people think that maybe you shouldn't ever intervene. I'm not sure that that's exactly correct. So this is published in the Canadian Journal of Cardiology, looking at lots of different data and summarizing at least what our practice is here in Canada. And that is that if someone has a heritable aortopathy or Marfan syndrome, FTAD, SMAD3, that you should intervene at 45. So that's what this document says. And 40 to 45, if they've got a worrisome family history, if their aorta has been dilating at a rapid rate. So you want to take, if they have a history of hypertension, so you want to take all of those other things into consideration, and you can move that threshold down based on your clinical judgment. Loeys-Dietz, 40 to 45. Like I said, vascular Ehlers-Danlos is just contraindicated. BAV at 50, and then Turner's they have at 27, but really it's probably 26 when you look at all the data. What about aortic surgery? So I'm really going to summarize this because I think we have a number of surgical talks later today. But during pregnancy, type A dissection, right? That's a no-brainer. They go for surgery. Progressive aortic dilatation. So if we're seeing that somebody's growing rapidly over the course of their pregnancy, you're going to want to think about intervening, and that's when you get your cardiac surgical colleagues involved. And then, of course, type B dissection, pharmacologic therapy, and periodic MRI assessment. And that is in line with the ESC guidelines as well, but again, based on no evidence. What about strategy for type A dissection management in pregnancy, right? So timing is really important here, depending on when somebody presents with a type A dissection. If it's in the first trimester, then you operate, and you do fetal monitoring over the course of surgery. You take all of your precautions that I'm not going to go into, and you hope for the best, but you know that there's a high fetal mortality, upwards of 20 to 30%. The third trimester is kind of a no-brainer. You do an emergent C-section, get the viable fetus out, and you operate. It's the second trimester where you really need to think about it. Is the fetus viable or not? And if the fetus is viable, then you're going to think about doing a C-section and operating, and if not, then you're going to go straight to surgery to have the aorta repaired and do fetal monitoring, and again, take all the necessary precautions and hope for the best. What about imaging and medical management in pregnancy? So we've talked a lot about echo and MRI, and during pregnancy, monitoring of the ascending aorta, and I say ascending because echo is really for that, the ascending aorta, and even that can be very challenging depending on the patient, depending on their windows. And so you're going to monitor the ascending aorta every 4 to 12 weeks during pregnancy, and don't forget, 6 months postpartum. So the postpartum period is also a high-risk period. You can't just forget about the patients during that time. And I give you a wide range, 4 to 12 weeks. And the reason is because it's really going to depend on the patient. It's going to depend on whether they came into it with a dilated aorta, what their underlying family history is, what their absolute aortic diameters are that are going to determine how often you're assessing them. And if they develop hypertension along the way, that's another reason to perhaps perform it more often. But again, the limitation is just the ascending aorta. Again, with echo, though, the other considerations include looking at that mitral valve prolapse if they have it, looking at the severity of mitral regurgitation that can increase during pregnancy, looking at their ejection fraction. And what about MRI during pregnancy? Again, if somebody has known aortic dilatation going into the pregnancy, so they were seen preconception, they had an MRI performed, and their aorta is dilated but not at the threshold, or they've chosen to get pregnant anyways, you should consider doing at least one MRI during pregnancy to visualize the entire aorta to ensure that there's been no change. If they've had no prior MRI, like the patient that I just discussed, you should consider doing the MRI in pregnancy. And again, non-contrast, 3D, MRA, it's preferred to CT because of the lack of radiation. And again, pre-conception, you do the MRI so you have a good comparison. Spinal MRI, if they've had no prior spine MRI, consider it in pregnancy due to cervical spine stability, scoliosis, dural ectasia. These are all important things to consider when you're thinking about, maybe the patient requires general anesthesia at some point, intubation, epidurals, spinals. The anesthesiologists need to know this going into it. Fetal ultrasound, consider it every 4 to 6 weeks. These women are on a beta blocker, which is associated with IUGR. Fetal echo at 22 to 24 weeks if you're worried about underlying congenital heart disease. What about medical management? So very strict blood pressure control during pregnancy. And so you want to ensure that these women are off their ACE and ARB, and you're going to use a beta blocker, we usually use metoprolol or bisoprolol, being the ones that are thought to be safest throughout pregnancy in women with heritable thoracic aortic conditions. And atenolol is associated with IUGR, so we avoid atenolol. And if they have Ehlers-Danlos 4, then celiprolol is a good option, as it's also used outside of pregnancy. All right, this is good because I think I'm almost out of time. So, role of IVF in pre-implantation diagnosis. So this field is exploding, and I should admit that my experience with pre-implantation diagnosis is limited because I refer them on to the fertility clinic or to genetics. But we'll talk about IVF. And so IVF, as you know, these are the steps outlined, and the red arrows point to the particularly high-risk times, right? So ovarian stimulation and the time of embryo transfer. So what are the steps? You stimulate the ovaries. There's oocyte maturation. You retrieve the eggs. Fertilization occurs, and then the embryo is transferred back to the uterus. There's a 2-week wait, and you do a pregnancy test. I make it sound simple, but it's not at all simple, and it's very taxing on the couple and on the prospective mother. And the point to note about IVF is that it poses an additional risk on top of the pregnancy itself. So if you took any woman and subjected her to IVF, I shouldn't say subjected, or if she had IVF, there is an increased risk associated with having IVF. And then if you have a cardiac condition or you have an heritable aortopathy, the risk is further increased. And what is that risk? So when you think about that ovarian stimulation piece, that period of time is prothrombotic, and it can result in hyperstimulation syndrome. So there's large amounts of fluid shift and greater risk of thrombosis. These days, the fertility physicians will tell you that the risk of hyperstimulation is low. There's careful cycle monitoring. They use lower doses of follicular stimulating hormone, and they use antagonists, or gonadotropin-releasing hormone antagonists, to minimize the risk of ovarian hyperstimulation. But you really need to pay attention to that, because during this whole process, the woman is at risk of having issues with the aorta, specifically dissection, because of all of these things. This hasn't been looked at systematically, but I think will definitely be the object of future study. And then embryo transfer, really important. At least in Canada, I think the fertility clinics are quite cognizant in women who have other conditions or cardiac condition to do a single embryo transfer and not to you try to increase the success rate by doing multiple embryo transfers, but that's a really high risk endeavor. You're further increasing the cardiovascular changes that will take place, and there's more maternal and fetal complications with this. So in this population, you really want to do single embryo transfer. And then if you think about IVF really quickly, WHO class 4, pregnancy is contraindicated. IVF is contraindicated for the same reasons. WHO class 3, so those women with those intermediate aortas, you're really going to have a discussion about whether IVF is a good option, because they're going to be at that much more increased risk. And in fact, I would caution people against pursuing IVF if they're in that risk category. And 2 to 3, I mean, they just require close follow-up. And what about pre-implantation testing? So we talk about pre-implantation genetic diagnosis, and that's in combination with IVF. That's at the embryo stage. If you're interested in genetic testing during the first trimester, then that's CVS or chorionic villus sampling. Second or third trimester would be amniocentesis. And then, of course, post-delivery is testing in baby. So what is this testing pre-implantation? Again, it's combined with IVF. So I'm really just summarizing this, and the folks with a genetic background are going to kill me, but this is how I understand it. So the oocytes are retrieved, fertilized in the laboratory, and you have the embryo. So single cells are removed from each embryo on day 3 and tested. If you don't do it on day 3, then multiple cells are required day 5 or day 6. The DNA is processed and determine whether or not there is a gene that is present in the embryo. But I think the key thing to note here is that you need to have a gene to start with. So you can't just, I want to get tested. No, there has to be a gene that's already been identified with the couple or with the mom. And the unaffected embryo can be transferred to the uterus, and affected embryos can be humanely discarded. So this is a really interesting area. The first case was actually successfully performed in 1990, and it does provide an alternative reproductive option for couples that are at risk of having offspring with severe genetic diseases. And so there's a lot of sort of ethical considerations when it comes to this, and it is that initially, when this was offered, and it's not offered everywhere, is that it was severe genetic diseases of childhood onset that you would consider perhaps doing this. So cystic fibrosis is a good example of that. And now it's extending into the adult onset conditions that maybe don't have a cure or are particularly lethal. So when you think about thalassemia major, Huntington's, spinocerebral ataxia. So there's a creep and it's increasing, and it has to be looked at carefully, and certainly is offered in some of our patient populations. Marfan syndrome is a good example of that, and there's some now publications that are coming out with respect to that. But I'm going to close now, and I think the important take-home is really the importance of having a multidisciplinary team to look after these patients. And so if you're not at a center that has a multidisciplinary team, then you need to identify the center where you can send these patients. So our particular site is the heart center, or the cardiac, one of the major cardiac centers in BC, that also happens to have maternity unit and high-risk obstetricians and MFM. And with that comes, cardiac and fetal imaging, hematology, cardiac surgery, cardiac anesthesia, cardiac intensive care. And so that all needs to be considered. And then, you have to have an approach. So if you have a patient that has a heritable aortopathy and contemplating pregnancy, that's when you need to identify them. But it's much better if you identify them even before they contemplate pregnancy and start to have these discussions. Refer them to one of these centers where they can have counseling. And if they're pregnant, you refer them to one of these centers to have a care plan developed. If they're low risk, they can be returned to their home center to be delivered and looked after. If they're moderate to high risk, they can be co-managed by the local hospital and the expert center with a plan to deliver at the expert center if needed. Thank you.